Before diving in and introducing our speakers, we wanted to open with a land acknowledgement. So we are hosting this session today for those of us on the West Coast from the unceded and ancestral territories of the Musqueam, Squamish, and Tsleil-Waututh First Nations. We're also lucky to have team members and attendees joining from other territories across North America as well. So again, welcome and welcome back if you have joined us for these sessions before. My name is Marie and I manage communications here at Thrive Health. Today's discussion will be on the future of eHealth solutions for rural pain care. So before we kick things off, just a few housekeeping notes. You'll see on Zoom, we have a Q&A tab. Please enter questions through the Q&A tab. We will answer them live throughout the session today. And we will endeavor to address every question that comes in. We'll be moderating the tab to make sure we don't miss any. So you'll get your questions answered. Please also note that we are live streaming this session on LinkedIn and also recording it as well. So without further ado, I will introduce our speakers and pass the mic. We are grateful to be joined today by Dr. Kimberley Kaseweter, clinical lead researcher at Thrive Health, and Nina Gregoire, who is also working at Thrive Health through the Mitacs research program. Dr. Kaseweter has worked to gain extensive research experience and expertise in chronic pain, patient care, eHealth, and advanced statistical analysis. She holds a PhD in health psychology from the University of British Columbia and is an adjunct professor with the psychology department at UBC Okanagan. Her research is currently focused on optimizing patient and provider experience, as well as improving the collection and usability of patient-reported data. Additionally, her work with Thrive Health has involved partnering with healthcare providers to develop, deploy, and evaluate solutions that support their clinical work and patient engagement. Nina Gregoire holds a master's degree in social psychology from the University of British Columbia, Okanagan, and is currently a doctoral and law student. Her academic interests focus on applied health research, communication, health equity, and ethics. Her internship with Thrive Health has involved surveying patients and providers to create a research-informed waitlist platform for patients awaiting care at pain clinics. And leading the charge on the Thrive Health side today as well is Dr. Mark Nazemi, who will be facilitating the conversation. Mark is Thrive Health's Manager of Clinical Solutions and Innovation. Without further ado, Mark, I will pass it to you.
Thank you for that introduction, Marie. Welcome, everyone. I think we'll just get right into it. Maybe we'll start with getting a sense of an overview of rural pain care. And what are some of the current roles of eHealth solutions from your perspective, Kimberley?
Sure. Thank you, Mark. I think that sounds like a great place to start. Also, thank you for having us both today. We're really excited to be a part of this discussion. So I'm sure many of you know, but for those who don't, chronic pain is notoriously difficult to treat or manage. And I think one of the main reasons for this is that it often presents with very complex physical and psychological comorbidities. So for example, individuals with chronic pain often experience other symptoms in addition to their pain, including anxiety, pain catastrophizing, depression, and insomnia. And all of these can be very difficult to manage just on their own, let alone when combined together. And so because of these comorbidities, the effective management of pain is really dependent on interdisciplinary care. So the gold standard here being, of course, multidisciplinary pain clinics. But in Canada, access to these clinics is actually quite restricted. So we have very few or very limited numbers of these clinics across Canada. And we also have very long wait lists at these clinics. So even if you're lucky enough to be referred to one, the wait alone could be anywhere from a few months to a few years. And also in Canada, we have a lack of funding for allied health services. So even if you wanted to seek out this interdisciplinary care on your own, other barriers still remain. So for example, in BC, we do have MSP coverage to go see a doctor, but the same doesn't exist for allied health. So even if you have private healthcare insurance, a lot of individuals with chronic pain would still end up having to pay out of pocket for services like physiotherapy, massage therapy, counseling. And so these options might not be available for many. And so these are just some of the pain points that are experienced in the management of chronic pain generally, but these challenges are often compounded in rural and remote areas of Canada, where patients often face even greater health disparities. So for example, individuals in rural settings often have restricted or limited access to care, so fewer healthcare services available in their community, which would then require or necessitate a need to travel for their medical appointments. And this travel could be costly both in terms of the price of travel itself, but also in terms of delays in treatment. We also know that in rural communities, they're home to more Indigenous individuals and also individuals who are lower maybe in socioeconomic status. So existing health inequities for these populations are then further exacerbated as a result of these geographical barriers. And this is supported by research, which has shown that rural residents do experience poorer health overall, as well as more chronic conditions and shorter life expectancies than their urban counterparts. And then in terms of chronic pain specifically, we also see that individuals in these regions often report higher levels of pain and more severe functional impairments. And I think this is important to consider, especially in BC, where I think it's about 13% of our population actually do live in small, rural, and remote communities. And then I don't mean to sound too negative, but we did see further complications in our pain care with COVID-19. So we saw increased rates of chronic pain in general, as well as higher levels of those mental health comorbidities. So again, anxiety and depression. And as a result of this increased demand that was then placed on our healthcare system, we're also seeing higher levels of burnout among the physicians and healthcare practitioners. So thankfully, and on a more positive note, trying to advance this slide, there we go. On a more positive note, one potential strategy for addressing these challenges is actually the integration of eHealth into the delivery of pain care. And this is an area that we've seen a lot of recent expansion, improvements, and innovation. So in the past few years alone, we have seen a considerable rise in just the number of digital healthcare technologies and apps that are available. And this can provide health professionals and patients access to support and care where previously it might not have been available. So I think I'll actually pause here and pass it to Nina, who could provide more details around eHealth.
Thank you, Kimberly, and thank you for having us today. So yeah, as we know, the onset of the COVID-19 pandemic, it really forced everyone to pivot, and healthcare was just no exception to this. Nearly overnight, the pandemic necessitated a widespread global adoption of virtual care. And in fact, one recent Canadian study found that the percentage of in-person office visits fell by just over 79%, and virtual visits rose 56-fold during the pandemic. So this is promising because the adoption of eHealth into pain care can lead to numerous benefits for both patients and providers. So this can include the decreased need to travel, reduced wait times for specialty care, increasing access to allied health professionals, lower healthcare costs for patients, all of those types of things. And then similarly for providers practicing in low resource areas, eHealth technology can offer a really unique benefit, and this can address other barriers that have been raised by physicians. So for instance, Project Echo is a knowledge sharing network for pain providers, and it connects clinical experts with primary care providers through telehealth to share best practices in pain management. It helps them overcome geographical barriers to education and increases providers' overall competency and confidence in treating chronic pain. And so adopting eHealth in day-to-day practice can help by automating certain clinical tasks, such as the collection and scoring of patient-reported data, so that physicians can really redirect their time to other aspects of patient care.
Wonderful. Thank you so much for that introduction into the space of chronic pain and especially targeting rural communities. I'm wondering, since both of you have conducted research in this particular area, if you can provide some details on that research. And particularly, I think what would be important to know is, how do patients and doctors feel about using such eHealth type solutions for remote care management?
Sure, I can take that question. So user perception of eHealth technology is actually something that both Nina and I were really interested in learning more about. So as you mentioned, we did collaborate on 2 research projects that were designed to gain insight into current perspectives on eHealth technology and in pain care specifically. So the first study that we conducted focused on perspectives from primary care providers and pain specialists. And then our second study focused on perceptions of patients who were waitlisted for pain care at a pain clinic in British Columbia. Sorry, just trying to advance the slide again. There we go. So before I jump into the methodology and findings, I do want to acknowledge that these projects would not have been possible without the support of our very talented research team, who you can see here. So of course, we'd like to thank you, Mark, for all of your help with these studies. We'd also like to thank Dr. Francois Lowe, who's a pain specialist at Bill Nelms Pain and Research Center, as well as Dr. Susan Holtzman and Dr. Paul Davies, who are both professors in the psychology department at UBC Okanagan here in Kelowna. Additionally, both of these projects were supported by Mitacs Accelerate grants, so we just want to thank Mitacs as well. So then back to your question, I'll start by giving an overview, I think, of the methodology and then the findings for the provider study, and then pass it over to Nina. So for the first study, we used a cross-sectional design to assess physicians' current needs and barriers in the delivery of pain care. We also wanted to explore their practices and attitudes towards eHealth technology. And so just for a little background, there have been a few other recent studies on this topic in Canada, but they really tended to focus on a specific pain condition. So really narrowing in on maybe low back pain, cancer, fibromyalgia, or a specific health profession. So just looking at perspectives from maybe rheumatologists. And then the data collection for these studies mostly occurred before the COVID-19 pandemic. And then the few studies that took place after COVID-19 mostly focused on virtual visits. So the goal of this research specifically was to get a wider perspective from physicians in general and ask about a larger variety of eHealth technologies. So to do so, we recruited physicians from across a broad spectrum of healthcare settings. So these are providers who worked in primary care, pain specialty clinics, and hospitals. We also recruited from both rural and urban areas of BC. Additionally, data collection occurred approximately 1 year into the pandemic, which I think was peak time for both changes in the delivery of pain care, as well as that urgent need for eHealth. So I do think this was a great time to be asking these questions. And to take part in the study, participants had to be a physician that was licensed to practice in British Columbia. They also had to treat pain to at least some degree as part of their practice. So in total, we did recruit 100 physicians, and 48 of these indicated that they practiced in rural settings. So I'll just be focusing on the findings from that subset. So when we looked at the responses, we saw that the vast majority of rural physicians expressed considerable interest in using eHealth in the management of chronic pain. So specifically, we did see that 81% of the rural physicians so that they would use eHealth in the management and assessment of chronic pain. And then the most preferred features that we saw were the electronic collection and scoring of data. So this might include intake, questionnaires, and patient-reported outcomes. And that was at 82%. And then patient-generated summaries at 72%, and tailored treatment plans coming in at 67%. And these preferred features really did map onto the biggest barriers that were reported in the survey by our physicians. So for example, one of the most prominent barriers that emerged was a lack of time to manage the complexities of chronic pain. So automating the collection and scoring of intake data and patient-reported outcomes or PROMs could really help free up more time for the physicians to then redirect that back to other important aspects of care. So I think I will pause here and pass it to Nina to talk about the patient perspective, as she did lead that study.
Thanks, Kimberly. So the patient study was conducted in just a really similar fashion, but with a different theoretical framework that applied to the patients. And previous studies have found that many people who are waitlisted for pain services experience, really significant deteriorations in psychological well-being and their health-related quality of life. And then unfortunately, despite the overall effectiveness of interdisciplinary pain clinics, just not all of the patients who go will experience treatment success. And this is partially due to the high attrition rates that they experience, and that is partially due to the psychological decline. And then there's also been the patient experience with eHealth being somewhat different. So in general, research has found that patients have expressed that high quality virtual care can lead to increased feelings of empowerment, improved self-management, increased access to culturally appropriate care, and reduced barriers associated with traveling. So things like costs, lost work wages, and then eHealth technologies have been found to be helpful across multiple domains. So for example, apps treating anxiety have been found to reduce this negative state, and the online delivery of pain education classes has demonstrated a reduction in psychological constructs that really do contribute to patient suffering. So in this study, we asked 79 rural participants about their waitlist experience and the role of eHealth and what it could have done during the wait. And respondents were patients with chronic pain who were being treated at Bill Nelms. And Bill Nelms has satellite offices. So while their main clinic is in Kelowna, we were able to survey patients who really lived all over BC. And then just to give you a snapshot of the patient demographics, the average age was 55, but they ranged from 19 to 88 years old. And we had 25% who identified as male and 75% identified as female. And then about 45% of the respondents attributed their pain to some sort of injury. And then the remaining was due to like natural processes or unclear origins. And so we had a pretty even split between rural and urban. And so it was a 60-40 split with 60 urban and 40 being rural. And then on average, patients were in pain for about 6 years before they were even referred to a pain clinic. So this is a long time to be in pain. And 60% said that their overall health worsened to some degree while they were waiting. And so this is a finding from our study. And then 35% said that they experienced no change. And only 5% felt some type of improvement while they were on the wait list. And then participants also reported feeling low levels of control over their pain, but then high pain intensity. And there was no statistical difference between the rural and urban participants in these questions. And so where we did see a difference was in what their actual barriers to pain care were. And these were things like transportation and accessing suitable services. And this was listed at just a much greater rate in rural respondents. And then we got feedback that in some cases, the community didn't really even have allied services such as massage or physio. And then if they did, that they weren't taking new patients. So we also got feedback that for rural patients, they face long commute times and extra expenses on top of the ones that we've mentioned earlier. So things like a hotel or needing a loved one to take time off work to drive. So it's likely that these kinds of real life barriers would influence their responding around eHealth and what they would want to use in eHealth. And so in this regard, rural patients were favorable to using a self-management platform and indicated about a 71% likelihood of engaging with it if it was free and provided through their clinic. And then when asked about the types of features they would like to see, we saw the highest endorsement rates for pain education and tips, self-management tools, information about supplemental services, in their areas, and then being able to flag notes for their providers. So what does this mean? From this finding, we've kind of extrapolated that there's not a big difference in the actual experience of pain itself for rural and urban patients while waitlisted, but there is a difference in treatment and management approaches. So then these differences give rise to the tools or features that they desire in an online platform. And for rural patients, there seems to be a strong willingness for a self-management approach when they're given the tools and means to do so.
That's really interesting to see this high interest from both the physicians and patients regarding using these eHealth platforms, and certainly in a remote area, accessing physical services may be quite a challenge due to the transportation issues that you mentioned, and just in terms of just the logistics of trying to access these. And I'm wondering, how difficult is it for physicians and patients in such rural areas to adopt eHealth solutions? I was wondering if you can expand on that.
Sure, I can take this question. That's actually a good question and something I was really interested in. So although we've seen a considerable increase in the availability of and interest in eHealth technology, and like you just said, strong interest from both patients and providers, we're actually still seeing generally low adoption rates for many other forms of technology. And even though we did see that, that stark increase in uptake in virtual care since the start of the pandemic, recent evidence does suggest that it was a much steeper uptake in urban settings and rural settings. So again, we're still seeing barriers that are hindering that use of eHealth. And the fact that it's not increasing at the same rate in rural areas where it could be even more beneficial, I think is something that's important to consider. So if we look at the findings from our study, even though we saw that the vast majority of physicians said that they were interested in using eHealth, when we asked about their current use in their day-to-day practice, we saw low adoption rates for several forms of technology. So although they were using things like EMRs and EHRs every day in their practice, only a small percentage of providers reported using eHealth to collect intake data, patient-reported outcomes, as well as for remote patient monitoring. So you can see here, you can see that only 10% of our rural physicians indicated that they're using eHealth for patient-reported outcomes, despite this being their most preferred feature. So a lot of them indicated they wanted to use eHealth for the electronic collection of scoring of data, but only 10% were doing so. And then when we asked physicians about why they're not currently using eHealth in their practice, the most common barriers that we saw were the cost and complexity of the technology itself, as well as just not being familiar with the available options. So as we know, there's a lot of options out there, some of which are supported by research, some of which are not. So just not being familiar with those options. Additionally, several physicians stressed that for any eHealth platform to be useful for them, it had to integrate with their EMR or EHR. And then on the patient side, some concerns that were expressed regarded internet reliability. And this might be surprising given that I think it's 94% of Canadians that have access to high-speed internet in Canada, but this is still not the case for everyone. So in most rural and remote settings in Canada, broadband internet is still not either available, not affordable, or it's just too slow for things like virtual visits, online classes, or accessing or downloading resources. In fact, it was 2017, I believe, that they reported that 97% of urban homes had high-speed internet compared to just 37% of rural households and only 24% of households in Indigenous communities. And then in 2020, several months into the pandemic, internet speeds were still found to be 10 times slower in rural areas than urban areas. So a very large gap in internet access and speed still exists. So then based on these findings, I would suggest that in order to achieve widespread adoption of eHealth technology, we do need to have equitable access to high-speed internet in these rural areas, as well as improved design, awareness, funding, and training for eHealth technologies. And this is both for providers and patients. So maybe this means things like offering more training in medical school on the different types of eHealth that exist, the different benefits of using these forms of technology, and then how to best integrate that technology into their clinical practice to improve their workflow. And then just as a last thought, which is something that I've already alluded to here, but the fact that it's still limited, we're still seeing limited uptake of technology despite the pandemic, despite the geographical barriers that exist in these rural areas, and despite strong interest from both patients and providers, to me really speaks to just how important these barriers are that remain. And I think it really does necessitate more research in this area, as well as improved design and innovation of eHealth. Hopefully that answers your question.
Yeah, and it's fascinating to still hear that, internet speed is one of the barriers, especially in these rural communities. And I hope that in the near future that we can, accommodate that and be able to improve access as well for them. So I'm wondering, how can we use digital solutions to develop procedures and essentially assist rural populations in managing their care?
Yes, I can take this one. So from the provider side, I think that providing features that allow them to maximize their throughput and increase patient time is really important. As we've noted, physicians wanted features that were kind of time savers. And so these are things like electronic collection and scoring of patient data, as well as summaries. And by having these types of features, clinicians have more time available to spend with their patients. And we also saw the endorsement of tailored treatment plans. So having things that are automated and tailored can also help reduce the physician workload. And then to that end, from the patient perspective, I think that having patient journeys can help them self-manage and potentially reduce the amount of contact with their provider, which can prove very convenient for the patient. And as mentioned, online platforms for other types of conditions have been found to help reduce symptoms. And then similarly for patients in pain, we've seen that online classes and seminars have been useful to reduce some of the negative psychological states associated with pain. So for instance, there's a brief course and it's about 3 hours and it aims to reduce catastrophizing. And the course shows a lot of promise. And it's not a cure, but it does help people living with pain. And it's been shown to reduce their suffering to some degree. So I think that offering this type of online material can have a sort of cumulative effect on the positive outcomes. And then also important is that other research has shown that engaging patients in small change approaches and teaching people that not everything is lost as soon as you get off track, because it happens to everyone, is really important. And then rural patients specifically expressed that having information and tips was important to them. And so having things that can build on itself over time seems like something that they would enjoy. And then additionally, we saw some differences between the rural and urban patients in their responding. So I think that when we employ or test new products, we really need to be making sure that we evaluate how they are working for rural and remote patients specifically. And this means, I think, designing things that can be used offline, that autosaves their progress. And this is really important for people with unstable internet connections, because if you have to keep putting your stuff back in, you're going to become frustrated very quickly. And so removing any type of friction in general makes things more appealing for end users. And no matter how great or useful something is, you're just not going to use it if it is too frustrating for you to use, or it's too glitchy, or you have to keep reloading it or resaving it, or you're losing everything. So you just get frustrated and give up. And so these are important aspects to consider for these folks.
Yeah, and Nina, certainly what you mentioned around tailoring, I can see how overwhelming it can be trying to, as someone living with pain, to try to figure out what would work for them. Is this right for me? Is there evidence behind it? So, certainly technology can really support that guidance for people to be able to navigate, through these resources and be able to really feel supported, as they're accessing self-management resources. And so I think that leads to our next question, which is, how do you see the future of pain treatment in rural areas in light of, some of the options that are currently available to people?
Yeah, good question. I do think eHealth is going to play an important role in pain management in rural communities going forward, and particularly so if we continue to collect and incorporate feedback from rural patients and providers throughout the design and the implementation phase. So because the uptake of technology is just so reliant on the context or the environment in which it's going to be used, it's really important that we design and we validate these eHealth platforms within these settings. So like Nina mentioned. And going forward, Nina and I specifically, we do hope to use this feedback that we've received from the providers to optimize the existing technologies and features that we already have, so at Thrive specifically, and then pilot these changes in rural settings. And I do think that if we can help minimize these barriers, then eHealth is not only going to help with streamlining clinical workflows, but I think it's going to lead to the development of just new care models in general, so better models. So we're going to see less fragmented care, hopefully. Patients are going to feel more in control of their own health. We'll have enhanced communication between patients and their providers, but also between the members of their care team. So I think if implemented correctly, eHealth will lead to improved care coordination in both rural and urban areas. Additionally, along with the greater adoption of technology in the healthcare field, we're also seeing an increase in just the amount of health data that's being collected. So I think from a research perspective, having access to this rich health information throughout the patient care journey is going to be really helpful for providing a deeper understanding of just the experience of chronic pain, as well as the overall effectiveness of different interventions. But more than just aggregating this data together, I think the next step is really learning how to optimize this information to then provide personalized health insights back to the patients and their providers so that they can use that information to improve their pain care, as well as improving our algorithm-based tailoring that you mentioned, so that it can really be matched to patients' unique needs and then reduce some of that burden that's falling onto physicians. And then this optimization of patient data is really an area that I'm most excited about pursuing in my own research here at Thrive. So maybe I'll pass it over to Nina to talk specifically about some research we have planned on the patient side.
Thanks, Kimberly. Yeah, so based on feedback from patients, we recently did develop a self-directed online waitlist intervention. And this intervention was really designed to positively impact patients while they await care. And we do hope that this intervention will be particularly beneficial for individuals in those rural and remote settings. So as a next step, this intervention will be piloted at a local pain clinic and their satellite rural locations so that we can ensure the information is accessible, understandable, and something patients actually do want to engage with, and not just kind of from our own theoretical standpoint and what the numbers say, I guess. So going forward, we do think that eHealth may decrease these health inequities and disparities that are really faced by people who are low in resources, rural, remote communities. And these critical barriers and inequities do continue to exist. And this includes limited access to and use of eHealth technology. And that's just a kind of sad reality. And if the design and implementation of these technologies ignores these barriers and realities, then we really do face the risk of kind of widening that chasm that exists between the two. So we want to try to make sure that we, face this in a way that is organized and applied and meets everybody's needs, especially people who are most at risk.
No, absolutely. And, with a rising aging population and just seeing, the stats around just chronic pain in Canada, which is, I believe, 1 in 4 have chronic pain. It's, a major population that, is living with this disease. And I think this is now a good time for us to answer some questions from the audience. I already see a few popped in. So the first one is, eHealth sounds like a pretty broad umbrella term. Are there any examples of eHealth technologies that you could speak to that provide some benefits to people?
Yeah, sure, I could answer that. And this is a great question because, yeah, eHealth is definitely a broad umbrella term, as Kimberly alluded to earlier on. So generally, I think we can think of eHealth as just virtually anything related to computers and medicine. And we sort of touched on these throughout the talk, but I'd say the most familiar form of eHealth for the general public during the pandemic was virtual visits. So all of a sudden, people were able to Zoom with their doctor or therapist, and we saw a ton of benefit from that. And the majority of people have expressed that the hybrid model of care is really important to them, and they don't want to give up that convenience of being able to get a refill or ask a question or go to therapy on their lunch break. So that was kind of a real upside of COVID. And then next we saw the rapid expansion of things like chatbots. And these are apps that we can kind of tell our problems or symptoms to, something like Wobot or Netscape. And it gives you something to try at home or provide some information in a validating way. And then there's a lot of technologies that are used by practitioners, and these can be really useful for them in a lot of ways. And it makes sharing data with other practitioners easier, for example, reduces storage, increases security, and then can simplify tasks. And then there are apps that work in similar ways for patients, and these are often in the form of health trackers. And they can really be incredibly useful for people with chronic conditions. So an example from the pain sphere is a person who gets migraines, and then inevitably they'll see their practitioner, and the practitioner will ask, did anything trigger your migraine? And it could be food or stress or poor sleep or their cycle. And by tracking your migraine, it might elucidate what that common trigger is. And maybe the person can't fully avoid it because we all know there's no way to avoid stress. But maybe if it's a certain food, they can cut that out and then avoid the migraine. So I hope that kind of answers the question. But
yeah, absolutely. I mean, there's lots of tools out there. And I think the next question actually ties into that. What are some of the tangible ways trust can be enforced when using online healthcare services? Because there's a lot of them out there, and, how do we trust which ones are safe to use?
yeah, that's a great question too. And I can take a stab at this, Kimberly, if you want. So yeah, I think this is something that we all care a lot about, and there is a lot of diversity in this space. And so there's a lot of things that come into play, I think, when we talk about trust in eHealth, and especially with eHealth being, again, such a broad domain. So aspects like the quality of the platform, ease of use, effectiveness, transparency, all these things come into play. And this is borne out in the research. So for example, without getting into politics, but I think a great recent example is the criticism and mistrust that built for some people around the COVID-19 ArriveCan travel app. And some of the common complaints were around how complicated it was to use, the glitches, the privacy breaches, and the uncertainty around who was able to access the data that was stored on it. And so similarly, we've seen with rural residents, they've reported similar kinds of trust concerns in eHealth. And one common concern is that they don't know who is accessing their data because they're not always able to visually see the provider when communicating their health information. And so they just don't know. So I think some tangible strategies that would build trust would be having reliable, high quality systems with state-of-the-art security features. And things like two-way authentication and facial recognition, they can kind of be a pain, I know, but these features, I think, make people feel more secure when they are trying to access their specific private data. And then additionally, seeing some benefit from use is really important from both a trust and motivation standpoint. So providing high quality, well-sourced approaches is fundamental. And I'd also note that when a provider is the one who is referring someone to this product, it's really important for it to actually work. Otherwise, that trust can then be broken. So just if it's a program or a virtual visit, it has to be effective for patients to have faith in it. And then other strategies to enhance trust could include preference for voice messages over text messages coming from your physician or care provider, and using a familiar voice when you're delivering the message. So this is like being able to recognize their doctor's voice on the other line. And then outlining clearly who's going to be viewing your health information is also really important. How it's going to be stored and shared, how it's going to be used, and why we're collecting certain information. And then this kind of loops into the transparency thing that I was talking about too, because lots of times we have these giant privacy statements and they're full of legalese and convoluted phrasing. So ideally having some bullet points of the really important terms that are written out at the average reading level for Canadians is critical. And it is absolutely shocking, I think, to wrap our head around the fact that nearly half of Canadians do read at below a high school level. So this is below grade 10. And then 17% of all Canadians fall into the lowest level of reading. And an example of this is if you pull out your medication bottle and read the instructions, they're not able to then interpret those instructions in a meaningful way. So what does that mean for privacy and consent in the eHealth space? I think we can safely say that kind of the largest proportion of you, or not the largest, but a large proportion might not be fully understanding or meaningfully understanding. So we need to make sure that we're actually gaining informed consent. So we kind of have to reposition lots of these things to be accessible at about a grade 6 level for the average Canadian.
No, I mean, that's a really good point in terms of the transparency involved in terms of, how the data is being used, who has access to it, the sharing component, and even what you mentioned around, having your doctor involved in your care. I think that collaboration is so important to nurture trust between the patient and the provider. But, there are, as you mentioned, interesting ways that can be done, not just using, text messages, but using voice recordings so that you feel the support that you're receiving from your provider. So that's really fascinating to me, actually. And I think just building on this question of trust, we have an interesting question here. So the question is, what is being done for clinically managing pain and addictions that have occurred because of prescriptions? Can this be managed together if the pain is still occurring, or must treatment be separate?
That's a good question. It might be outside of my expertise. I am not a physician, but what we did hear from physicians is that this is a challenge. So a lot of the providers in our research indicated that dealing with the opioid crisis in Canada is very, very challenging. So the protocols that are outlined for them are confusing or vague. There's just not enough information. A lot of the younger doctors who are taking over older practices are just inheriting these patients who are just entrenched in opioid addiction. And it makes for very difficult care. I mean, in addition to those comorbidities that we talked about, those mental health comorbidities, care is just so complicated when it comes to chronic pain. And so I do think in terms of the eHealth perspective, I think that there's something we can do to help physicians there so that it can be managed together. And so I think at Thrive, we are actually building something around opioid tapering and management to facilitate that for physicians. But yeah, I'm not sure if I'm the person to necessarily answer this question. It's a great question.
I would just jump in, Kim, with there was like a couple comments in your study that you ran that talked about too, like the integration between the EMR and any solutions that we do build, so that there's like a hub and spoke model so that people aren't fully disjointed, so that, you know, other practitioners and then the patient and then any allied health, so that everybody's kind of on the same page where it comes to that opioid use. And so I thought I would just tag in.
Yeah, no, I agree. And like bringing in the pharmacists as well, like having that connection, it's just not, it doesn't exist right now. And eHealth does have the risk of like making that fragmentation worse if not done correctly, because, you know, we have different apps that don't connect to each other. They don't talk. But if we can connect all those providers together, then that care is just going to be managed better. Then the patient isn't retelling their story to every person. It doesn't feel like they're going to different places. Our care actually feels like more coordinated, more part of like one journey. And I think that is important.
Yeah, certainly. I mean, and you know, just to add a few more points to that, I think, you know, absolutely, with chronic pain being so complex and, you know, having to approach it from that biopsychosocial perspective, certainly an interdisciplinary team is needed to, you know, address all the issues. But in order for that to be successful, there needs to be that clear line of communication between the providers. And I think, you know, tying to that is the education component as well. There's a lot of stigma around, you know, having chronic pain. It's an invisible illness. And so, you know, being denied services or, you know, looked at, you know, in terms of a patient that is trying to, you know, get medication, even though that's not really the case. They're looking for the right treatment. You know, I can certainly see how some of the work that we're right now doing around flagging for, you know, risk of opioid dependency, I think those are things that we can help in terms of creating the right treatment plan to support people, you know, recovering from their symptoms. So it's a complex issue. It's a complex question to answer. So hopefully that shed a bit of light in terms of what we're thinking. And I think perhaps even the next question may have some alignment to that. So what are your thoughts on AI and machine learning in the healthcare field?
Good question. Interesting topic. And again, maybe not my area of expertise necessarily. But I do think that AI, machine learning, other algorithm-based tools are going to have a lot of potential and promise in healthcare. I see it offering the most value, I think, in terms of initial screening and patient triaging, and then tailoring self-management and community resources. So maybe using information such as patient symptoms, preferences, and those geographical locations. So where are they, what resources are available, and then tailoring it to that patient. And then also offering some patient guidance, support, and motivation, validation via things like chatbots. So this is an area where we're seeing a lot of expansion as well. So maybe sending patients encouraging messages as they're working through self-management modules, providing some guidance when they're navigating their healthcare journeys and making appointments, things like that. At the same time, I do think we need to be careful, particularly around diagnosing medical conditions. So the accuracy of any of these models really depends on the availability, the completeness, and the accuracy of the data that it's receiving and using. So again, if patients in rural communities are just not empowered to engage with eHealth, they don't understand what's being asked of them in the questionnaires, the language is maybe confusing or misleading, and they don't have reliable internet access, then we're going to end up with missing or incomplete data that's going to result in inaccurate models. So I think the reliance on it, we just have to be a little bit careful, particularly around that. And instead, I do see it not replacing the care of doctors, of course, or maybe even diagnosing, but rather delivering meaningful insights and information to physicians in a way that could then facilitate their clinical decision-making and again, save them some time.
Absolutely. I mean, it's another sensitive issue in terms of making sure that even from an ethical standpoint, the right data sets are used and that the recommendations are evidence-based and informed from that clinical lens. We have a couple more questions. How can patients and providers get involved in future research projects and play a role in design?
Good question. So we do have some upcoming projects. We're always looking for user feedback, insights, piloting. So I think that you could reach out to me directly, but Neha, do we have a slide that had the information for where we can reach out?
I think the next slide.
I don't have the control anymore.
Maybe someone from.
Oh, there we go. Yeah. So if you're interested in research opportunities, you can email us at info@thrive.health. And if you're interested in any of the interventions that we're developing or these kind of journeys, you can also get in touch with us at that link there.
Wonderful. And we have one more question. And I actually think this is an interesting question. So how do we encourage pain specialists and specialized pain clinics to adopt some of these eHealth strategies and tools? Because it seems currently that everything is always a one-time interaction rather than a journey. Any thoughts on that?
Yeah, I mean, oh, sorry, Nina, go ahead.
No, your thoughts are better than mine often, so go for it.
No, I was just going to say, I think that really fits nicely with Thrive Health, and the mission here at Thrive Health is to create those journeys as opposed to a one-point solution. So we're not trying to target just one thing. And I think that's the problem with a lot of eHealth that's out there. So many different apps, so many different platforms that don't speak to each other. They're created by different people and they all target different aspects of healthcare. So maybe it's the collection of intake data, collecting patient-reported outcomes. You have the EHRs, you have appointment bookings, you have self-management. And I mean, I can see why a physician would be reluctant to take on all of that. I mean, we already have so many different logins that they have to look at. They're getting so much data. So things like for diabetes, you have Dexcom, you have all of those sensors, they have just endless logins. And I think adding even more to that, there's going to be some resistance. So I think if we want to encourage physicians to adopt this technology, we have to make it more integrated with the EHRs, the EMRs. We have to make it more than just a one-point solution in their care journey. I hope that answers the question. And maybe Nina, you can add to it if you had something else.
Yeah, I would just say that if we start early on in each individual patient's journey, so like at that waitlist period or at onboarding, and kind of maintain their data and provide useful feedback to the physician. So things that we were talking about that will really save time as opposed to creating more work. I think that's another way, right? So if we can track patients over time and deploy questionnaires and do things that really can give benefit and help do the tailoring and kind of create an entire journey for that patient, I do think that it will, by the patients feeling more satisfied, perhaps physicians will kind of feel mutually excited about it along with their patient.
Yeah,
Exactly.
I think also,
go ahead. Sorry. No, go
I was
ahead.
just going to say, I think that's why it's so great that we can include providers as kind of these partners in the design of these eHealth solutions and features that we have, just so we can make sure that it is something that they want to use and that's fitting into their workflow. And they're giving us insight that we wouldn't have just as an outsider. So we don't know what is all being asked of them, what they're already doing, and having them actually tell us what it is that they want and how it would fit into their clinic. I think that's what's going to help us get there as well. Sorry, Mark, you can go.
No, absolutely. I mean, that's on point. And I think, what we're seeing, especially with the research that you're both doing, is that we're moving away from these transactional care points to supporting people in this longitudinal way because of their chronic conditions. So that tailoring, and this is where AI and machine learning can play a big role in terms of learning the condition of that person over time, and then suggesting and recommending to nurture that collaboration with their providers to support patient care. So definitely an exciting future, and we're looking forward to hearing more from your research work as well. We have a few minutes left. I don't know if there's any last minute questions. No more questions. If you do are interested to learn more about the research that Kimberley and Nina are doing, you can directly reach out to them. Otherwise, maybe I'll pass it back to Marie for closing.
Yes, thank you, Mark, and thank you, Kimberley and Nina, for a fantastic discussion. Neha, if we could just go back to the previous slide quickly. Yeah, so as mentioned, anyone with further questions or interested to learn more about our research work at Thrive Health can send us an email at info@thrive.health. We also have a contact form through our website where you can send us a message there as well. So we look forward to hearing from you with any questions or follow-up you have. Otherwise, I think we're probably safe to give everyone about 7 minutes back in their day. So wishing everyone a wonderful day.
Thank you so much for having us.
Yes,
Thank you. Have a good day. Bye.